Well, here we have our capillary, and we notice that blood is entering from the arterial end via an arteriole, and we know that once the blood is somewhat deoxygenated, it is exiting via the venous end. And the capillaries are very close to the tissues of the body, so here we have some body cells. Could be any tissue, but they're the body cells there. Now, what we want to look at here is the physiology of the capillaries and tissue fluid. And the first thing to notice are the various pressures that are involved here. Now, you do see slightly different figures quoted, but the pressure in the arterioles, because it's come from an artery, is relatively high. It's got the effect of the cardiac contractions propelling the blood through the arterial system. So when the blood comes into the arterial end of the capillary, it's about 35 millimeters of mercury pressure. Then as it goes through, the pressure drops, and by the time we get to the venous end of the capillary, it's down to about 16 millimeters of mercury pressure. Because as we know, the venous system is a lower pressure system than the arterial system. Now, in plasma, there are some large plasma proteins. Large plasma protein molecules. As well as the cells and everything else, there's these large plasma proteins. And they are very large. The most common plasma protein is albumin. And that's got a molecular weight of 69,000, so it's a very big molecule. And then there are globulins as well, the immune proteins, even higher molecular weight, 140,000 their molecular weight. And there's a little bit of fibrinogen as well, the clotting protein. And that's even bigger actually, that's 400,000 molecular weight, but that doesn't matter too much. There's all these plasma proteins. The main one is albumin. The albumin contributes actually about 80% of what I'm going to talk about. And what I want to talk about is the combined effect of these plasma proteins is going to generate an osmotic pressure of about 26 millimeters of mercury. Now, some people give a slightly higher figure, but we'll live with that for today. Now, of course, you know that there's lots of water molecules in plasma as well. There's lots of water molecules. And you'll know that there's other substances in here, such as ions. So there's lots of ions as well. Sodium, potassium, chloride, a little bit of magnesium, a little bit of calcium. Now, the sodium is a very osmotic molecule. So sodium will dramatically attract water. But the point is the sodium can go in and out through these small pores quite easily. Sodium is actually water soluble, it goes in and out through these small pores. So what it means is that the concentration of sodium in the plasma and the concentration of sodium in the tissue fluids is pretty well the same. So there's not a great osmotic difference between these two compartmentalizations of body fluid. The sodium's pretty well the same on both sides, as is the chlorine, as is the potassium. It slightly depends on how you measure it, but we can say it's basically the same. So there's no great osmotic effect because the sodium, the chloride, the potassium, they can fit through these pores. They're very small molecules. So the concentrations are roughly the same on either side. So there's no differentiation of ionic concentration that would account for an osmotic gradient. But the plasma proteins, because as we've already said, the albumin's got a molecular weight of 69,000, it's a huge molecule, that can't fit through these gaps, these intercellular clefts. Now, diagrammatically, I've drawn these clefts as being quite big. In reality, the clefts, these gaps, only occupy a 1/1000th of the surface area, the internal surface area of the capillary. So 1/1000th of the surface area of the capillary are these gaps. But that's quite enough to let the sodium in and out, and the other ions in and out. But it's not big enough to let the plasma proteins through. So the plasma proteins are going to be retained in the plasma. So these are the plasma. Let's draw them bigger so we remember. They're big molecules. Now we'll see later that small amounts of plasma protein do escape. They're not really supposed to, but they do. But for now, let's just say that these are retained within the plasma, within the blood, within the intravascular compartment. Now, there is, some people say, slight hydrostatic pressures, fluid pressures in the tissue fluid, but it's way smaller than the hydrostatic pressure here. So what we mean by the hydrostatic pressure is the blood pressure in here is 35 millimeters of mercury. And the pressure of that, the hydrostatic pressure, is the pressure that this 35 millimeters of mercury exerts on the vessel wall. That's the hydrostatic pressure. So sometimes there might be a little bit of opposing hydrostatic pressure here, but it's hard to measure it. So basically we'll count the hydrostatic pressure here as being nothing, as being zero. So what we actually have is here we have 35 millimeters of mercury pushing out. And this osmotic effect here is trying to suck in. So the osmotic effect is trying to suck in. Let's draw arrows that way. So this is trying to suck in. So we can think of these plasma proteins as suction molecules. They're trying to osmotically suck water in. And we've got 26 millimeters of mercury there. So there we've got 35 pushing out. We've got 25 sucking back in. So that gives us a net filtration pressure of 9 millimeters of mercury. So can you see that? There's 35 pushing out, 26 trying to suck back in. So that will give us a filtration pressure of 9 millimeters of mercury. And of course that's positive, and that's going to cause the filtration of tissue fluid. Now actually there is a little bit of osmotic pressure in the tissue fluid. So this figure would be slightly higher if we count the osmotic pressure in the tissue fluid, because that would be tending to suck water out. But it's very small, so I'm not going to include it in the calculations. It gets a bit cluttered if you do that. So what we have is tissue fluid being formed at the arterial end of the capillary. So we now have tissue fluid. This of course is essential because it's the diffusional medium between the blood and the cells. The oxygen doesn't jump to the cells. The oxygen from the red cells goes to the tissue fluid before it goes into the cells. The carbon dioxide from the cells goes into the tissue fluid. As does everything else, as does the nutrients, as do the vitamins, as do the minerals, as do the waste products. They all diffuse through this medium of the tissue fluid. Now, as we go along, the pressure is going to drop. And here, the pressure has dropped to 16 millimeters of mercury. So I think you can see now that the hydrostatic pressure pushing out is 16 millimeters of mercury. But we've still got this 26 sucking back in. So that means we've got a reabsorption pressure of 10 millimeters of mercury. But this is pushing out, and that is going back in. That's 10 millimeters going back in. So the suction effect of the plasma proteins has overcome the hydrostatic pressure within the capillary, so the tissue fluid is going to be reabsorbed. So as we noticed on the previous video, we have these processes of filtration and reabsorption. There's reabsorption there. And that's going to give us, this is what gives us the interstitial fluid. The fluid in the tissues. as opposed to the fluid in here, which was intravascular. So the only difference between the fluids outside and the fluids inside essentially is the presence of these plasma proteins. Now, if we added up the osmotic effect of the sodium and the potassium and all the ions, this will give us an osmotic effect of thousands of millimeters of mercury. But because they're the same on both sides, that's pretty well cancelled out. So we see the difference is the presence of the plasma proteins. So what we're actually talking about here is the blood colloid osmotic pressure. So this is the blood colloid. A colloid is a solution of water with big molecules in it. And the big molecules here are the plasma proteins. So what we sometimes call this is the oncotic pressure. So the oncotic pressure is the pressure generated by the plasma proteins. And because the other osmotic effects balance each other out across the capillary membrane, it's the oncotic pressure which is responsible for the reabsorption of the tissue fluid. So the hydrostatic pressure pushing out, the oncotic pressure sucking back in. And of all the water going through here, all the water going through in the blood, about 1 part in 200 is filtered. And most of that is reabsorbed. The majority of that, maybe 85% of that, is reabsorbed. It simply goes back in at the venous end of the capillary. And people have calculated that all over the body, maybe 20 litres a day of tissue fluid is formed. And about 17 of that is simply reabsorbed. It's simply reabsorbed. But of course that leaves another 3 litres or so that's not reabsorbed. Now, if that 2 to 3 litres was allowed to remain in the body tissues, pretty soon we'd suffer from edema, wouldn't we? The tissues would become edematous. In the UK, we spell that with an O. In the US. Logically, I must say, you don't have the O. But we don't want that. It's a pathological situation. So as we've said, we've got the tissue cells here. There's tissue cells. But not all of the fluid is being reabsorbed, and we don't want edema to develop. So what we actually have is there's another network of capillaries here. Again, with individual cells. Another network of capillaries. But these capillaries have sort of fairly floppy overlapping cells like this. And there's millions of these structures scattered throughout all the tissues of the body, with these floppy overlapping cells. And what these are, of course, are the lymphatic capillaries. They're lymphatic capillaries. Again, made up of individual cells. Unlike the blood capillaries, though, unlike the vascular capillaries, the lymphatic capillaries are blind-ended. Now, what it means is excess fluid can come along here, and because these cells are flappy, they will flap open and let the water in. But once the water's in, if the pressure increases, that will flap the lymphatic capillary cells shut. So they're acting a bit like valves. They're flapping open to let things in, and they're flapping close to keep it in. And then of course once it's in, this will be transported away into larger lymphatic vessels, drained ultimately into the large lymphatic ducts that eventually drain back into the near the subclavian veins. So there's this lymphatic system. Now, we mentioned that the proteins aren't supposed to escape, but sometimes they do. The odd one gets out. And if these were allowed to accumulate in the tissues, let me ask you, if these were allowed to accumulate in the tissues, what would that do to the osmotic pressure in the tissues? Well, I think you can see it would increase it. That would attract water and the tissues would be edematous, which would be bad. So again, these cells flop open to let the plasma proteins that have escaped in, and these are returned to the blood via the lymphatics, via the entire lymphatic system, which there is a separate series of videos on if you want to watch it. And probably so 2 to 3 litres a day. So we've said 17 are reabsorbed back in. That would mean about 3 litres a day is drained via the lymphatic system. So this absolutely vital interstitial fluid. Actually, sometimes as well, of course, you could get bacteria in the tissues, and they're also taken away by the lymphatic system. That's why you can get swollen lymph nodes, because these are going to drain via lymph nodes. And occasionally, unfortunately, you can also get malignant cells in tissues, I'm afraid. These cells can go malignant. And again, these malignant cells can be taken away in the lymphatics, which for a time can compartmentalise malignant diseases. So fascinating area of physiology. Now what we want to do next, I'm going to leave that there for now. And next we want to talk about the abnormal pathophysiology that can develop to alter this beautiful intricate physiology, which is going on in you absolutely all the time. We want to think about some abnormal conditions affecting capillaries now. But just a quick resume of the normal physiology. Blood's coming in here, 35 millimeters of mercury, hydrostatic pressure, pushing out. By the time it gets to the venous end of the capillary, hydrostatic pressure's dropped to about 16 millimeters of mercury, still pushing out. The plasma proteins are generating this colloidal osmotic pressure, 26 millimeters of mercury, but that's sucking in. Now we can actually represent this graphically. So imagine we have a line along here, and that line is 26 millimeters of mercury, representing the colloidal osmotic pressure, or what we call the oncotic pressure, generated by the plasma proteins. So that is basically going to be the same all the way along the length of the capillary. So this 26 millimeters of mercury here is going to extend all the way along the capillary. It's not going to change significantly. But of course the hydrostatic pressure pushing out is going to change. Represented by the red line. So that's going to go from 35 down to 16. So this is the hydrostatic pressure. Pushing out. Now what this means is we can represent diagrammatically what's going to happen. So here the hydrostatic pressure is a lot greater than the osmotic pressure, so we'll get a lot of movement of fluid out. Here the pressure is a little less, but the hydrostatic pressure is still greater than the oncotic pressure, so we'll still get some coming out. By the time we get into the middle of the capillary here, then the pressure difference is much less, so we'll only be getting small amounts of fluid filtered. So here, at the arterial end of the capillary, because the hydrostatic pressure exceeds the osmotic pressure or the oncotic pressure, more is coming out. But when we get to the second end of the capillary, towards the venous end of the capillary, when the pressure is lower, then here the osmotic or oncotic pressure is greater, so we're going to get a little bit going back in. Here the pressure difference is going to be greater, so we'll get more going back in. And here there's a much bigger pressure difference, so we'll get quite a lot more going back in here. So that's what's going to happen in the normal situation. Now I want to tell you now about some abnormal situations, and I think the first one we'll look at, well, it's not really abnormal, but this one's about sweating. So here we have someone who's been sweating. Now if someone's been sweating a lot, the sweat is made from water, so they're going to have lost water from their circulatory system. If there's less water in the blood, can you see that means that the plasma proteins are going to be relatively more concentrated, because there's now more plasma proteins. Not because there's more plasma proteins in total, but because there's less water to dissolve it in, so they'll be more concentrated. They'll be more concentrated. So what we notice here is that at the arterial end of the capillary, the hydrostatic pressure is still greater, so we're going to get some filtration. But now we have a higher osmotic pressure. The hydrostatic pressures are still the same. The circulatory system is able to maintain blood pressure via compensatory mechanisms. Even in significant dehydration, you've got to be very, very dehydrated before you'll start becoming hypotensive. But what this means is that even as early as here in the capillary, the osmotic pressure is now, because it's higher, is now greater than the hydrostatic pressure, that difference there. And then here, pressure's greater still, so we'll get more going back in. And then here there's a bigger difference, so we'll get even more going back in. Because at any one time you've got about 3 litres of blood in the, 3 litres of water in the blood, 5 litres of blood in total approximately. 3 litres of that is water, but in the tissue spaces you've got 11, depends how big you are, 11, 12 litres of water. So we've got all this spare water. So what it means is after sweating, the increase in the osmotic pressure of the plasma will allow for restoration of blood volume, restoration of intravascular volume, because fluid is going to be reabsorbed at a greater rate from this spare fluid, is one way to look at it, this spare fluid in the interstitial spaces. Now of course it's better if you drink, because eventually this is going to become depleted and you will become dehydrated. But this physiology explains nicely why intravascular volumes and therefore blood pressure can be maintained even in the presence of really quite significant dehydration. So that's a really useful mechanism. Now the next one I want to consider is after hemorrhage. After hemorrhage. Now I think just before I look at this one I might explain a bit of physiology before we come back to this. So normally what happens is if we think about the blood pressure, in the arteries the mean arterial blood pressure might be 100 in the bigger arteries. So these figures here are MABP, mean arterial blood pressure. And in the arteries that can drop to about 90 as it goes through the arterial system. But then the pressure drop in the arterioles is significant, down to about 35 millimeters of mercury there. That's in the arterioles. So this is in the arteries, that's in the arterioles. And then when we get into the capillaries, there's going to be a further pressure drop, as we know, from about 35 down to about 16 millimeters of mercury. Going to be a pressure drop there, and then the pressure is going to be even lower in the veins. Now, if there's hemorrhage, there will be a profound vasoconstriction of the arterioles. So if that's a normal arteriole there, of that diameter, and we know they have smooth muscles in the wall of the arterioles, after hemorrhage, that's going to get smaller. Now that's good in a way because that's maintaining blood pressure, because blood pressure equals cardiac output multiplied by peripheral resistance, and vasoconstriction is going to increase the peripheral resistance. So it maintains blood pressure. But can you see that that means instead of having this much lumen for blood to go through in health, there's only that little bit of lumen there after a significant hemorrhage. So the arterioles will vasoconstrict. And can you see that means less blood is going to get through to the capillaries? So the capillaries will be relatively hypoperfused. So the pressure of the blood going into the capillaries is going to be less. So that now makes sense of hopefully this diagram here. So after hemorrhage, whole blood is going to be lost. Now if you lose whole blood in hemorrhage, if you're losing whole blood, so whole blood is being lost. We're losing blood. Can you see that means you're losing? That's what hemorrhage is. Hemorrhage is loss of blood from the intravascular compartment. Can you see that means if you're losing whole blood, you're losing the plasma, the proteins, and the red cells? So that means initially after hemorrhage, because whole blood is lost, it's whole blood that's left in the blood, containing the same proportion of plasma proteins as before. So the oncotic pressure is still going to be 25 millimeters of mercury. So after hemorrhage, the oncotic pressure is going to be 25 millimeters of mercury, normal. But can you see the capillary pressure is way lower because there's much less blood getting to the capillaries as a result of the peripheral arterial vasoconstriction. So what this means is even at the arterial end of the capillary, there can be some reabsorption of fluid from the tissue spaces, and as you see as we go along, that difference is going to get greater, and here it's greater still. So we get more reabsorption of fluid. So what this means is in the hour or two after hemorrhage, the osmotic pressure of the blood, because the hydrostatic pressure in the capillaries is reduced, that means that tissue fluid can be reabsorbed at a greater rate from the interstitial compartment. And again, that's going to restore the volume of the blood. That means you can take effective action. You can fight, you can run from predators, even after injury. Now, if you have a drink to restore the fluid, that's even better. But even if you can't, you're still going to restore your intravascular volume. That means you can restore blood pressure. That means you can carry on taking effective action. Brilliant survival mechanism, but based on this very simple physiology. So I think we'll leave that clip there, and then when we come back on the next clip, we'll do a couple more of examples from pathophysiology. Now, carrying on with capillary pathophysiology, this is the normal state of affairs here. Fluid being formed at the arterial end being reabsorbed at the venous end, and with a pressure change, as we saw in the previous video clip. Now, what I want to look at now is the situation where there is a hypoproteinemia. So hypoproteinemia. Hypo low, Protein is the protein, and emia, if you're English, you put an A. If you're American, US spelling doesn't have an A. Hypoproteinemia. This could be a generalised hypoproteinemia, as you would get in malnutrition, or there could be a hypoalbuminemia because the liver's not synthesising the albumin. But for whatever reason, there are low amounts of protein in the blood. Now, normally there's supposed to be the right amount of protein in the blood, because that's what gives rise to the oncotic pressure to facilitate the reabsorption. But if someone is not getting enough protein to eat, then their liver cannot synthesize the albumin. If someone's not getting enough protein to eat, their lymphocytes, their B lymphocytes, cannot stimulate or cannot synthesize the immunoglobulins. That's, of course, why people become immunosuppressed if they're malnourished. If they have not got the amino acids to make the antibodies, how can the B lymphocytes make the antibodies? They can for a while because they can break down protein, but basically malnutrition leads to immunocompromise. And if someone's malnourished, there's no amino acids going to the liver. And it's the liver that makes the albumin. So we're short of albumin. Should be there, but we're short of it. We've got low levels of protein in the blood. Now, what this means is that the pressures are the same, but now can you see the osmotic pressure has been reduced? So it should be up there, but now it's down here. So that means there's greater filtration pressures basically all the way along here. So in the normal situation, it's only the first half of the capillary where there's filtration, and the second half there's reabsorption. But now the hydrostatic pressure is going to be greater than the oncotic pressure for much more of the length of the capillary. That means we're going to increase the amount of tissue fluid. We're going to become soggy. This is edema. In England we say oedema with an O. So we become soggy. There's too much tissue fluid. So you've seen these appalling pictures of children with blown up tummies who are malnourished in famine situations. Because there's a huge vasculature, there's huge capillary beds in the mesentery. And the fluid will drain into the, or the fluid will accumulate in the peritoneal cavity. Because there's more fluid being formed because of the greater differentiation between the hydrostatic and the oncotic pressure, but less is being reabsorbed. So here there's less. There's some being reabsorbed there, but it's less than we would not like in the normal physiological situation, and we get these appalling pictures of children with blown up tummies. The fluid actually goes with gravity, really, so they get blown up ankles, puffy eyelids, edematous scrotums. And the treatment, of course, is to give them some protein, because if we feed them protein, if we do that correctly, the gastrointestinal tract can break that down into amino acids. The amino acids can be absorbed into the blood. They'll go to the liver, and the liver is perfectly capable of synthesizing the albumin, which will restore the oncotic pressure of the blood and will reverse the accumulation of excessive tissue fluids. And of course, we get a similar situation if we give too much water in fluid overload. Now, this can happen if someone drinks too much. Some psychiatric patients will drink too much. I think you call that polydipsia. Or we could give too much intravenous fluid, which is quite easy to do, especially in children. Remember, children have very low blood volumes, and it's very easy to infuse. That's why we're always ultra careful not to give children too much intravenous fluid. But if you get too much intravenous fluid, then the water, I think, again, you can see the water there is going to dehydrate. The water is going to over dilute. The excessive amount of water is going to over dilute the plasma proteins. And that means for a given volume of blood, you've got less oncotic pressure sucking back in. That means fluid can accumulate in the tissues. And if we give too much intravenous fluid, this iatrogenic condition of fluid overload, we can see the eyelids they get bags under the eyes that become puffy. But the main thing to look out for is the pulmonary edema. The patient will be orthopnic. They'll have orthopnea, difficulty in breathing when lying down. That's often the first thing that you see. So we need to sit these patients up, we need to stop the intravenous fluid, and we need to consider giving them diuretics. Of course, in malnutrition, we wouldn't give diuretics, we need to give protein. So the effect is the same there if we get lowering of the osmotic pressure in the blood. So we've seen that this simple physiology accounts for adaptation during periods of fluid loss, such as sweating or diarrhea and vomiting. It's life-saving after hemorrhage. And it also explains why we get edema in hypoproteinemia and fluid overload. So they're all variations of this basic normal physiology. But hopefully you knew at the moment this is what's going on. We're getting the formation and we're getting the reabsorption of the interstitial fluid, bathing all the body cells, acting as the transport medium for everything that's going to and from the cells. But I think, as we see now, being maintained in a dynamic way, with the potential to go wrong, giving rise to pathophysiological changes. The pathophysiological changes will give rise to clinical features, which we learn to recognise, so we can assess the patient, diagnose the condition, and treat them accordingly.